first, let's thank Dot Sweeney, Steve Duke, and Jim Crochier for today's beautiful program setup and tech and all of those good things. The programs don't run without any of them. And then Shirley, who I think you all know by now, Shirley, who works here, she created those adorable origami type cows on your table. There's a mama cow and a baby cow. Check them out. They're so cute. She spent a lot of time on those. Thank you to today's sponsors, Fallon Health, Regal Care. Thank you, Lee. She's in the back. Thank you, Lee. Vibra Hospital, UMass, Pivot Health, who's doing blood pressures in the lobby. And please also notice, we work very closely with QCC, the Hospitality Nutrition Program, and they created the back bulletin board over here on osteoporosis. So check that out. Oh, you took a picture, good. So check that out. May is National Osteoporosis Month. Got Bones is a powerful reminder that our bones deserve attention, care, and a little love, just like the rest of our body. Osteoporosis may be silent, but its effects can be life-changing. The good news, with knowledge, movement, and nutrition, we can all take steps to keep our bones strong and our lives active. Today we are here not just to learn, but to support each other, because good health is a team effort, and every one of you is an important part of this community. So let's take this opportunity to learn something new, ask questions, share stories, and celebrate the strength, both physical and emotional, that we all carry. Now we welcome Allison Money, nurse practitioner. Alice and I have been working on this program for months, maybe since last October. So she is so excited to be here today. She's a nurse practitioner, a member of UMass Memorial Medical Division of Rheumatology, Department of Medicine. She is going to talk about options for medication treatments, including common concerns and side effects. Also joining Allison today, please welcome Dr. Jonathan Chia from the Rheumatology Department, Allison's mentor, as well as Meredith Malaise, a nurse practitioner in primary care at UMass, who also does bone health management. Rhonda Hammer, who you all know, owner of Prime Movement and your beloved osteoporosis fitness specialist and health nutrition coach, will explore how nutrition, exercise, sleep, and stress management complement medical care. Rhonda will explain the Worcester Senior Center's 6-week program, Osteoporosis Beginner Fitness, starting next week, which I believe is almost sold out, and the Osteo Maintenance Fitness programs. Welcome all.
Thank you, Suki. This has been a long time coming. She said October, and I think we all met last summer to start the process of this. So I'm super happy to be here. Thanks for everybody that showed up. There are so many of you. This is my biggest crowd yet, so I feel a little bit like a local celebrity. This is fun. So we are going to talk about osteoporosis today. We're going to go over a lot of things. I'm going to try to keep it concise, but really run it how I run a typical appointment. I see some patients of mine in here today, so they're going to get repeat information. But we'll save all questions until the end. I'm going to present, then Rhonda will present, and we'll take questions after that. I don't know, conflicts of interest. This will be our overview. We're going to go over what osteopenia, osteoporosis are, how does it happen, how common is it, what symptoms will I have, how do you test for it, what does it mean, how do we treat it, what about the scary side effects you read about on the internet and you hear, and where can you learn more? So, osteoporosis is simply the process by which the bones become more porous, and when they are more porous, it increases the risk for fracture. Osteopenia is the precursor to that, still increases your risk of fracture, however, not quite as bad. These are some pictures of bones to for all you visual learners, you can see in the bottom picture, normal bone on the left-hand side and osteoporotic bone on the right-hand side. And you can see why that would break more readily than a normal bone. Common, about 54 million Americans have osteoporosis and low bone mass. It's often called a silent disease because you can't feel it. Unfortunately, until an incident happens, like a broken bone, you'll have no idea. 1 in 2 women and up to 1 in 4 men. So I'm happy to see some men in the audience as well, learning some stuff. And these are just some graphics about basically how much it costs us if we don't actively treat the osteoporosis. As I said, in most cases, there are no symptoms. A fracture is often the first sign. In some cases, loss of height is an indicator, or if the spine is starting to curve forward. Always during our appointments, we're asking people, do you feel shorter than you used to be? And if the answer is yes, then we have to consider that osteoporosis is certainly present. Why does it happen? So many reasons. Aging is probably one of the biggest, but there is family history, estrogen deficiency in women, smoking history, alcohol intake, certain medications, certain disease states, medical procedures like bariatric surgery or weight loss surgery, varying exercise levels over the course of your life, vitamin D and calcium intake, and diet. Here's a list of risk factors. So non-modifiable, we cannot change them. Unfortunately, we can't change the aging process, can't change race, female sex, early menopause. Slender build has a lot to do with osteoporosis, generally less than 125 to 30 pounds. Positive family history, there's certainly a family history associated with osteoporosis. And the things that you can change are your vitamin D and your calcium intake, your diet, estrogen deficiency in certain cases, sedentary lifestyle can be reversed. You can exercise, quitting smoking, not drinking, and lowering caffeine intake. So screening for osteoporosis. How many in here have had a bone density scan before? Yeah. Can you vouch that it's actually pretty easy? Yeah. All you got to do is lay there. It's typically done with what we call a DEXA, which is a dual X-ray absorptiometry, also called a bone mineral density, not to be confused with a bone scan because it's a different test. It's non-invasive, low-dose X-ray to determine the strength of your bones. It's basically you go, you lay down, the tech is going to position you how they want you positioned, and they will test, usually standard sites, which we'll get to. So who gets this screening? So you'll get a bone density, hopefully, if you have broken something, if we follow up with the way we want to treat you. But generally, we can start screening in women that are 65 and older, postmenopausal women that are less than 65, but if you've got certain risk factors, like you've broken something already or you happen to be very petite, certain high-risk medication, diseases, etc. Males generally 70 years and older or 70 years and older with risk factors. Anybody that is 50 plus with a history of broken bones, and just a snippet, generally insurance, once you start to have a screening bone density, they will generally cover every 2 years or so. So what do the test results mean? So when we look at your bone density, we are looking at something called a T-score. And your T-score is basically your difference away from what's considered a normal baseline. And a normal baseline is someone in their mid to late 20s. That's when we reach our peak bone density. I always tell people everything's wasted on the young. But that person, normal, has a T-score of 0 or greater. And the further away from that baseline you get into the negative, the more significant the bone loss. And osteoporosis is generally considered to be anything that's negative 2.5 or less at any of the standard sites we're looking at, which is usually the base of the spine, the total area of one of the hips, the femoral neck of one of the hips, which is like the skinny part between the ball and the long bone of the femur. And And then sometimes, if we can't use those sites, we will use the non-dominant wrist instead. So osteoporosis, negative 2.5 or less, and osteopenia, which is that precursor, is anything negative 1.1 to negative 2.4. If we see your bone density results and any of those T-scores are less than negative 3, less than or equal to negative 3, we automatically term it a very high risk for fracture. We also use something called a trabecular bone score, which is a newer addition on our bone densities within the past couple of years. And this, we cannot diagnose your osteoporosis with, but we use it to predict your fracture risk with an equation that we use called the FRAX. And the trabecular bone score gives us an indicator of the quality of your bone versus the quantity. So if you go back to my first slide that had the pictures of the bones, and the one with osteoporosis was really broken apart versus the one that was normal that had this nice thick mesh to it, it truly is like the scaffolding of your bones. It's the architecture inside those bones. And the higher, the better. Anything 1.32 or higher is considered normal, and then we've got the degrees of degradation there. And like I said, we can't diagnose your osteoporosis with it, but it's a good indicator to us what the health of your bones is. This is a picture of the FRAX calculation. We don't do this in our head. We have an online calculator that does it for us, but we take into account lots of different factors that we go through with you. So it's your height and your age and your weight and your bone density, that T-score that we're using. Were you ever a smoker? Do you drink alcohol? Do you have chronic steroid use? Things like that, that all factor into making this decision. And so in the red, on the right-hand side is somebody's 10-year fracture risk prediction. And you can see below it in the blue, if we adjust it using that trabecular bone score that I talked about, the risk actually changes. So it's a good example of how a better TBS reduces your fracture risk long term. So in addition to a bone density, when we see you, we'll do a lot of workup. We always like to get x-rays of your back, the middle part of your back, the lower part of your back, and that's to look for compression fractures. We also do a bunch of lab work to rule out what we call secondary causes of osteoporosis. So we go through usually a whole slew of questions with you to get a basic history. And we can tell a lot based on that history, but there is some other stuff that we can't figure out just based on those questions, so we like to do that lab work to investigate a little bit further. So what's a compression fracture? What are we looking for on those x-rays? So compression fractures happen in the spine. The vertebrae are stacked nice and neat like boxes on top of each other. And when somebody has osteoporosis and those bones become porous enough, those vertebrae can just squish on themselves. Sometimes one side will squish more than another. They are an indicator of underlying osteoporosis because in somebody with normal bones, they don't just do that. And these compression fractures are tricky. Sometimes they hurt a lot and you would absolutely know that they're there. And other times they are completely asymptomatic. And so sometimes the presence of these can change what we're recommending for treatment. And so you can see in the red boxes, those are the abnormal ones. If you look at all the other ones, they are pretty boxy, and all the ones in the red boxes are not so boxy. Lab work is to, like I said, rule out other factors that can contribute to your bone health, usually including a vitamin D and a calcium to be sure that you're getting enough. We measure your thyroid, we measure your parathyroid, basic blood counts, we check your kidney, we check your liver function, we screen for celiac disease, other blood diseases, and these help us determine if there's other causes of your osteoporosis, and oftentimes will help guide treatment and which medications will be safe for us to use with you. As far as treatment goes, lifestyle measures are the easiest well, I shouldn't say that. They're not the easiest, but they are the simplest to change. So vitamin D and calcium are the mainstays of your bone health. In most cases, whatever else we're deciding on for treatment, we always want you on vitamin D and calcium to maintain an adequate level. So in general, we're recommending about 1,200 milligrams of calcium a day. This is between your diet and any supplementation. A maintenance dose of vitamin D is usually between 1,000 to 2,000 international units a day. In addition to D and calcium, weight-bearing physical activity most days of the week is very important for your bones. To break down the calcium recommendations a little, 1,200 milligrams daily with diet and supplementation, combination of both is usually the most common. It is available over the counter and in so many formulations. It is so confusing. Everybody walk into the pharmacy after having a doctor tell them you need to take calcium and just look at that shelf and be utterly overwhelmed. There's so many choices. So you have gummies and you have chewables and you have huge tablets and you've got capsules and all the things. So it's not necessarily that one is any better than another for everybody. Everybody's a little bit different. So calcium carbonate is probably the most frequently found over-the-counter supplementation, but there's also calcium citrate. Calcium citrate tends to be better for those that have acid reflux, which is no fun. It's absorbed a bit better. And then we usually tell people if you're on carbonate to try to take it with food to help with its absorption. The over-the-counter supplements, too, they're going to come in loads of different doses. There's 200 milligrams, there's 500, there's 600, there's 1,000, there's 1,200. And basic rule of thumb here is when you look at that supplement, try not to take any more than 500 to 600 milligrams at a time, because that's just about as much as the body's going to absorb at any one time. And if you take more than that, you're just going to excrete it. We love dietary calcium. We prefer it. It tends to be better absorbed, better tolerated, because sometimes calcium can cause people a little bit of GI upset. Diarrhea isn't often one that I hear. And so dietary calcium is great because your body simply absorbs it better. So foods high in calcium are dairy products, leafy greens, nuts. There's resources online to find. You could just simply Google foods high in calcium, and it's going to spit out a whole list of foods for you. So here's just some examples of everything that you can get over the counter as far as calcium is concerned. Like I said, chewables, tablets, petite versions, calcium plus vitamin D. There's those Viactive chews at the bottom, which I'll vouch for are delicious. There's a caramel and a chocolate one. And then various food sources. So a lot of people make smoothies every morning. Yogurt is great, cheese, cottage cheese, ice cream, milk, almonds, almond milk. Vitamin D, also available over the counter, and a maintenance dose is usually 1,000 to 2,000 international units a day. To make it confusing, we also measure it in micrograms, which 1,000 to 2,000 is going to be 25 to 50 micrograms. And those should both be on the bottle if you go to the pharmacy to look for that. Not a lot of great food sources of vitamin D, unfortunately. Anything that you are going to get in your diet is going to be fortified. They'll fortify some cereals or breads or things like that. But most of the time, in New England, especially in the winter, you're going to need a supplementation of vitamin D. D3 is probably your best choice, unless you've been told otherwise. Exercise should be a combination of weight-bearing and muscle-building activities. You never lose the capability to build your muscle. So don't think just because you're older that it is not worth it. Walking, weighted activities, body weight activities, resistance bands, aerobics, functional movements. I'm going to defer to Rhonda to really talk to you in detail about her program and the exercise itself. But there's also a website that I put here, which unfortunately you can't just click on and go to, but it's the Bone Health and Osteoporosis Foundation. Even has some online videos that you can watch that'll teach you a little bit more about those exercises and safely how to do them. Medication treatment. So we talked about lifestyle measures, D, calcium, exercise. And oftentimes with osteopenia and osteoporosis, we have to use medication because osteoporosis is a progressive disease. If we don't do anything about it, it generally will worsen year after year. The ultimate goal is to reduce your fracture risk. We can't ever bring that fracture risk down to zero. Can't make promises that you're never going to break anything, but medications help to reduce that risk long term. And in general, I like to tell people we have two ways that we can treat it. We've got meds that are designed to slow the progression down so that it doesn't get so bad so fast year after year. And then we've also got a group of medications that can actually rebuild the bone. We reserve those bone rebuilding therapies for people that are the highest risk for fracture. So people that come to see us that have a T-score that's already less than -3, people that have broken something before. Those are the people that really qualify for those bone rebuilding options. And your risk for fracture is really what determines what we choose. So this is a synopsis and a list of anabolic is bone rebuilding, anti-resorptive is bone maintaining, so to speak. So I'll use those terms interchangeably. I'll try to be consistent. But the anabolic therapies stimulate new bone growth. One is called abaloparatide, which is Tymlos. One is called teriparatide, which is Forteo. And one is called romosozumab, which is Evenity. Anybody heard of these or seen commercials for these? I see commercials for Evenity a lot. Yeah. And then the anti-resorptive or bone-maintaining therapies are for people at moderate to high risk of fractures. And those are designed, like I said, to slow how quickly osteoporosis progresses, and that's because it slows how quickly the body is naturally turning over old bone. These include alendronate, which is Fosamax, which I'm sure a lot of you have heard of. And then there's also other oral options called abandronate, which is Boniva, resendronate, which is Actonel. There's one called zoledronic acid, which is Reclass. That one is an infusion. And then there's also one called denosumab, which is Prolia. And that one is an injection. So it comes in all different forms. And we base the decision on many different factors about you. So anti-resorptive treatments, the goal here is to stabilize your bone density. If we start you on one of these and we have a baseline bone density, what we're looking for when we repeat that bone density is that things haven't changed. If we see that they haven't changed, great. We can say that we have successfully been treating your osteoporosis. There is a timeline for use on these. Some of them we use for up to 5 years. Some we'll use for up to 10 years. There's oral IV injectable formulation. And one of the big take-homes here is that we don't like to use those oral medications in people that have a baseline heartburn because their biggest side effect is more heartburn. So those are the oral bisphosphonates. They're all oral tablets. Fosamax is once a week. Boniva is once a month. Actonel is once a week. You pick your day. You make it your medication day. It has to be taken first thing in the morning on an empty stomach with a full glass of water. And you have to stay upright for 30 minutes after you take it. And that is because that biggest side effect is heartburn. For some people, this can be really easy and it's appropriate. And they say, great, give me the pills. I will take those, no problem. These are kind of the hardest medications to maintain or adhere to. Sometimes people don't take anything else, so they don't remember that they have to take their pill once a week. Sometimes if you forget it 1 week, you think in your head, oh, it's only once a week, how important could it be? It's okay that I forgot it. But it is designed to be taken weekly, or monthly can get even harder. Like I said, heartburn's the most common. Body achiness is common. Sometimes you can get diarrhea. These are used for up to 5 years. Oftentimes what we'll do when we see people, if we have a baseline bone density, we'll put you on this for a couple of years. We'll remeasure your bone density a couple years down the road. Like I said, insurance is generally covering them every 2 years. And if that repeat bone density looks good, we'll give you a break from that medication. We call that break a holiday. It makes it seem a little bit more fun. But we give you a break, we give your body a chance to kind of get back to itself, and then we'll again continue to reassess that bone density to make decisions about future years of treatment. Zoledronic acid, which is reclassed, is simply an IV version of those pill medications. And it doesn't cause any GI symptoms because we bypass the GI system. This is given through an IV. Usually at the infusion center, and the total length of that appointment is a couple of hours from start to finish. By the time you get there and they check your vitals, they put the IV in. The medication itself infuses over about 30 to 45 minutes. And after that, they'll watch you for a period of time, and then you go on your way. And you don't have to go back for a year. So people like this one because it's convenient. You don't have to think about taking any pills or doing any injections. You go, you let the nurses do all the work, and then you go home. About 25% of people will have a flu-like reaction to this, so fever, chills, body achiness. You could feel a little bit crummy for a few days following the infusion. It will usually settle in within 12 to 24 hours after the infusion, and then not typically last any longer than 24 to 48. The best way to combat this, I usually tell people, take a dose of extra strength Tylenol the night before you go, the morning of, and the night after, and stay really hydrated, and you can help to minimize those symptoms. Again, because this is a very similar medication to the pills that I just talked about, we'll use it for up to 5 years. We don't always use it that long, but generally 2 to 3 years, and then we reassess things to make decisions about future treatment. So this denosumab, which is Prolia, is the injectable formulation of medication. So it works by a little bit of a different mechanism than the other two that I just mentioned, but again is designed to slow progression of osteoporosis. This is an injection very similar to a vaccine, given every 6 months in our clinic. Usually tolerated really well. I don't hear a lot from patients in regards to sickness following their Prolia, but you could be a little bit achy maybe for a day or two following, or sometimes you can get an injection site reaction similar to when you get a vaccine. This is every 6 months. We can use it for up to 10 years. We say 6 months, we mean 6 months. You stay on it, and then after you hit that 6-month time frame, it's all out of your system. So there is an importance to timeliness with this. You cannot abruptly discontinue it, say, oh, you thought to yourself, I don't feel like getting my Prolia anymore, and you stopped. There is a rebound risk for fracture associated with its abrupt discontinuation. And so that is why there is that importance of timeliness. And if we ever make the conscious decision to take you off of it for whatever reason, say you've been on it and your bone density looks good and we think you can come off of it, we usually have to transition you off of it with another medication to reduce that risk for fracture. This is a good choice for people that have chronic kidney disease as opposed to the other medications that I just talked about. So now we'll switch our talk to the anabolic, which is bone rebuilding treatment. And what these do is they stimulate the cells of the body to make new bone. And by the time you get to like 60, 65, your body on its own is not really making a whole lot of new bone. So these medications help kind of wake up those tired cells with the goal to improve your bone density and see improvement in those T-scores. So say you had a negative 2.5, which is osteoporosis, potentially we could improve those T-scores to a point of normal with these medications. Duration of treatment is based on whatever med we choose. One is 1 year, the other ones are 2 years, and it's really individualized based on your risk for fracture, your health history, and sometimes, unfortunately, insurance. Romosozumab, which is Evenity, is the newest medication on the market for osteoporosis, which we've been using clinically for the past 6 to 7 years. It's a once-a-month injection given in clinic for 1 year total. So once a month, you have to come to our clinic. You see the wonderful nurses. They will give you your injection of Evenity. And then after that year is complete and you spent the time rebuilding your bone, we transition you to one of those medications that's going to help maintain your bone. So you build and then you maintain at that higher level. Common side effects include injection site reactions. So again, similar to getting a vaccine. Body aches for a day or two. Headaches are potential. Tend to see those only in people that are prone to headache at baseline, but worth a mention. We do find that this is generally one of the best tolerated and most effective medications. There is, however, a low risk of heart attack or stroke associated with its use. So in certain cases, we are limited with who we can and cannot use it with. These two, abaloparatide, which is Tymlos, and teriparatide, which is Forteo, are both daily self-injectable therapies, and these ones are for a total of 2 years. So these come in a pre-measured syringe. You don't have to do any of the measuring. You get the little needles that twist onto the end of the pen. Your responsibility is to twist that needle on, you click the pen, you hit the button, and you usually administer in your abdomen. You can use the thighs too. Thighs are okay. We just ask that you rotate the sites because sometimes they can get irritated, so that's one of the most side effects. Again, with this one, following that 2 years of treatment total, you'll transition. You'll spend the time building and then transition to a medication that's going to help maintain your bone at that higher level. Injection site reaction is common, I mentioned. Also, dizziness following the injection. About 10 to 15% of people will get a little bit dizzy after they give themselves this. It's related to a blood pressure change. The best way to combat that is to give it to yourself at nighttime, and then by the time you wake up in the morning, you're totally fine. What about my jaw? Who is so scared of side effects? Who's read about osteonecrosis of the jaw or knew somebody that had something that had something? Yeah. This is probably one of the scariest, but also one of the most rare complications of medications we use for osteoporosis. Anti-resorptive options, which are the pills, the infusion, the injectable, as well as a low risk with Evenity, carry a very low risk of something called osteonecrosis of the jaw, which we'll talk about. They also carry the risk of something called an atypical femur fracture. The risk for each of these is remarkably low, a less than 1% risk in general. Usually when people come to see us, the risk of fracture is significantly greater than the risk of side effect associated with their use. Gross picture, sorry, should have warned everybody. This is something called osteonecrosis of the jaw, which is an area of exposed bone. Super rare, less than 1%. And it's a phenomenon. It's like having a dental infection without really having a dental infection. It's associated with how these medications play with the body's natural bone turnover. And it will typically present itself with some tooth pain or jaw achiness. You do not go to bed one day and then wake up the next day and have a necrotic jaw like this picture. It happens less in people that are getting routine dental care, which is why we stress the importance of seeing a dentist before, during, and after treatment for routine visits. Usually there has to be some type of infection as a stimulus for osteonecrosis of the jaw. And so if you're seeing the dentist on a regular basis and you're avoiding infection, then by and large you can avoid this as well. Management would be regular cleaning and monitoring. We take you off the medication if we can deduce that it was in fact the med itself that was contributing to this. Other risk is something called atypical femur fracture. So your femur is the long bone of your thigh, goes from your hip all the way down to your knee. And usually if people break it, it's going to be up at the hip or it's going to be down at the knee. People don't ever usually just snap it right in the middle like these pictures show. This happens, again, because we are playing with the way the body is naturally turning over bone. Sometimes you can get a little buildup of bone or what we call a pucker or a beaking in the middle part of the femur, usually on the outside. And it puts stress at the bone. So if you were to fall and you had this, it would break there instead of up or down at the hip or the knee. Sometimes it can happen, the bone will get weak enough, it will break and then you will fall. That is even more rare. But this will present as a dull achiness to your thigh. And if you ever came to see me and you said, Allie, my thighs are just achy, and I knew the medication you were on had the potential to cause something like this, we would get x-rays, see if it's happening. If we know it's there, you can prophylactically or preventatively pin it. Orthopedics does that so that it doesn't break there, and we take you off of this medication. Usually we're only seeing this happen if people are on their medication for longer than they should be. So I mentioned that 5-year timeline and that 10-year timeline very distinctly. When people initially were put on these medications years ago, 30 years ago or so, sometimes people got put on, nobody ever told them to stop. And you know, given the nature of medicine, we get smarter as we go on day to day. We figured this out. So that is why we have those timelines. So how do we measure success? Improvement or stabilization in those bone densities that generally you are getting every 2 years or so. And we can always say that if you have not broken any bones in the time that you've been on treatment, it is successfully working. I have some resources at the end if anybody wants to take a picture or write these down. This is for the Bone Health and Osteoporosis Foundation, which is a wealth of knowledge, as well as the another osteoporosis foundation. So you guys can utilize these to find out more information. I am done with my presentation, which was perfectly timed. And Rhonda's going to take over and tell you all about exercise in her program here. And then we'll answer some questions. Thank you.
All right, Jim, I did it. Look at that, all by myself. Where's Jim? I did it by myself. So, good morning. Everybody wriggle around in your seat, wave your hands. You've been sitting for 45 minutes, do something. Okay. So, I titled my portion of this presentation, Small Drops, Big Pond. The big pond is osteoporosis. Small drops are lifestyle habits that we can adopt for better bone health. You all know where you are. Most of you already know who I am. I am a health, nutrition, and fitness coach and osteoporosis educator. My name is Rhonda, and I do run the osteoporosis beginner and maintenance program here. So, what's our biggest fear with osteoporosis? I heard it. Breaking bone, how? Falling. Managing osteoporosis is all about keeping your bones strong and reducing risk of fracture. So for those of you who can't quite see that picture, do you know what that person's wearing? Completely wrapped head to toe in bubble wrap. We cannot go through wrapped in bubble wrap, correct? That would not be comfortable. It's not very fashionable, right? So lifestyle changes alone are not going to reverse or change or stop your osteoporosis, but it can significantly enhance the effectiveness of the medications that Allison talked about. We can give you the medications, but if you want, what happened? There we go. Add just a few more drops to that big pond, why wouldn't you? Right? Okay. So Allison already talked about the medications. Some that slow the bone loss, some that stimulate bone growth, some prevent breakdown and new formation. Okay. Now I'm going to talk to you about exercise. Weight-bearing and resistance exercises help maintain bone strength and density. We're going to talk about a little bit in a few minutes. What is weight-bearing exercise? So think about it. Some of you already know the answers to this. Okay. I'm going to mention some exercises. You can think about these. Walking, dancing, strength training. All of those can help improve bone growth, improve your balance, reduce your risk of fall, right? Nutrition. Allison touched on this as well. Diet rich in calcium, vitamin D, and protein supports bone health. The protein also supports your muscle health because we need to strengthen our muscles to strengthen our bones. They're attached. They go together. Okay? Dairy products, dark leafy greens, fish, fortified cereals. So that's where the very few dietary places you're going to find your vitamin D, that's the fish, your fatty fish. Mackerel. Y'all mackerel fans? No? We're having mackerel for lunch today. No? All right, never mind. So, how is everybody sleeping? How'd you sleep last night? Good? I like to hear that. Good. Poor sleep can negatively impact your bone health. And there's many ways that can happen. So we want good health. We want good sleep. So studies have shown that an inadequate sleep is linked to lower bone mineral density by interfering with the body's ability to repair and regenerate bone tissue. So we need to sleep. Anybody have any stress in their life? This is a completely stress-free room, yes? No one has any stress of any kind. Chronic stress increases cortisol levels. That's your stress hormone, and it can weaken your bones over time. So relaxation techniques, meditation, yoga, deep breathing can help with some of that stress. So let's do one of those together. Take a moment. You can keep your eyes open or closed. Take a nice big deep breath. Inhale. Exhale. think I'm dying. There we go. Studies actually show that if you sigh out loud, you exhale more and you feel less stress. So let's do that again. Ready? Inhale. And everybody go, ah. See, I felt the stress level go down already. That's great. Okay. So let's talk about exercise. We want to aim for 30 minutes of weight-bearing exercise most days, or activity. It doesn't have to be, oh, I went to the gym and exercised. It can be activity. Vacuuming, mopping, rearranging the furniture, whatever it is you want to do. What is weight-bearing? What does that mean? Anybody here bearing any weight? Where are you bearing it, mostly, currently? On your backside, right? I'm weight-bearing because I'm standing. I'm bearing weight on my feet. This is the kind of weight-bearing we're looking for, not on your backside. That's not the kind we're looking for. I mentioned a few exercises, so this is a quiz. Some of you should know the answers to this already. Is walking a weight-bearing exercise? I'm moving my weight across the floor, right? Probably not many of us doing it, but running, right? That's how fast I run. Running. What about dancing? Yeah, see my dancing? I'm a really good dancer. How about swimming? Is it weight-bearing? It's not weight-bearing. It could be strengthening. The resistance of the water is building up your muscles in your arms and your legs. Breathing in and out of the water helps with your lung capacity, but it's not weight-bearing. We weigh about 80% less in the water than we do on dry land. I want to be weighed in the pool next time. So can we arrange that at your office when we come in to get weighed? Can we do it in a pool? So weight-bearing. How about hiking? Sure. Elliptical machine. Sort of. How about riding a stationary bike or a bike out in the road? Riding a bike. Is that weight-bearing? Why is that not weight-bearing? Because you're sitting. What is making contact with the ground when I walk? And when I hike? And when I dance? And when I do jumping jacks? I'm not going to do jumping jacks, but do jumping jacks, right? My feet, my body's making contact. When I ride a bike, what is making contact with the ground? The tires of the bike. Yes, I'm weight-bearing here. That's about it, right? So those are not necessarily weight-bearing. They're really good exercises. They're good for you. If you have osteoarthritis, especially in your knees, that pedaling, that swimming could feel great on your joints, but it's not weight-bearing. So we're looking for 30 minutes of weight-bearing activity most days. Anybody feel like you're hitting that? Oh, I got a lot of nopes. A lot of nope. Okay. How about strength training? 2 to 3 times a week. What's an example of strength training? Lifting what? Lifting anything. I like that. Laundry, that is definitely a type of way of assuming there's something in the laundry basket. Yes, right? So lifting something. Could be weights. Could be a barbell. It could be dumbbells. When you're cooking, right? Sometimes when you're cooking, I guess. Picking up the kitty litter box. Picking up things. That is strength training. However, most of us aren't saying, okay, I'm going to get a full body workout by lifting up the litter box or lifting up the laundry, but making your bed is a little bit of strength training if you're lifting up that mattress. But we're also looking at resistance tubing, the weight machines in the gym that you set the weight for or pull the pin on, depending what kind of gym you go to. Here it's setting the dial, right? 2 to 3 times a week. How am I building better bones through weight training? I kind of gave you the answer earlier. Building better muscle. They're attached, right? I can't just stick a dumbbell on my shoulder and say, look, I've got stronger shoulders. I have to use my arms. And through that arm are muscles, ligaments, tendons, bones, working on those muscles. We can also use our body weight. Who wants to do burpees with me? Anybody? Who knows how to do a burpee? Oh, should we learn? No, maybe not today. How about those jumping jacks? That is considered body weight exercise. That does not mean it's appropriate for everyone with osteoporosis, okay? We also want to include balance exercises. How often should we do balance exercises? Every day, all the time, because the better balanced we are, the less likely we are to what? Fall. And if we don't fall, we're less likely to break something. You got it. less likely we have to walk through life covered in bubble wrap. It's not attractive. It's probably very warm. Nutrition. Calcium-rich foods. Name one. Fish is calcium-rich? How about ice cream? Definitely. Allison said you could have ice cream. I heard her. I'm taking that advice. Right? Dairy products, leafy greens, kale. Yeah, there's other things going on with spinach, but spinach, yes. Swiss chard, dark leafy lettuces. So it's not all, salmon has a little bit. So vitamin D, we can get some sun exposure, but we live in New England. What's it doing? It's bright out, but it's not sunny. So we need to take that supplementation. We need to get that vitamin D. A little sun exposure is not a bad thing, except your dermatologist told you to put what on? Sunscreen. So yeah, we're gonna need that supplement. We wanna make sure we're getting adequate protein that's gonna help us build the muscle that's attached to the bones. And Allison said the same thing. We wanna have a variety of foods in our balance. We're gonna get those nutrients from our food when we can. That means a varied diet. This up here is something called the plate method. We're looking at half of our plate of fruits and vegetables, a quarter of it being your whole grains, and then your proteins. So that's a great way, and that little blue circle is your fats, your avocado, your olive oil. I mentioned sleep. So for those of you who are not getting great sleep, setting a consistent bedtime and a consistent wake-up time can help you with your sleep. Creating a relaxing nighttime routine. That is not the time to check email, look and say, oh my gosh, this bill is due. Oh, I think the roof is leaking. That's not the time to worry about that. And then caffeine and screen time close to bed. I can't do caffeine after noon. I don't drink caffeine anyway, but if I accidentally have something with caffeine, it better be before noontime. Screen time close to bed as well. We want to turn things off. Start to turn this down so we can turn all of this down. Put the screen down. Read a real book. Listen to calming music. Do something. And I'm going to show you what you can do next because it goes with sleep. And that's stress management. Okay. Things stress us physically. Things stress us mentally, emotionally, right? But we want to manage that. Chronic stress is not good for us in lots of ways. Deep breathing. We all just did a little bit of that. Some people don't like the idea of meditation. It scares them. They don't know what it is. It's some woo-woo scary thing. Others of you practice it regularly, right? It can be as simple as just sitting still, closing your eyes, so now I have no blue screen, right? And breathing. Breathe in and breathe out. In and out. But you can do some gentle activities like yoga, or even taking a small walk, a slow walk. Not the power walk before bed. This is not how we're gonna walk before we go to sleep. Maybe it's a leisurely walk around the block, okay? But staying socially connected is really important as well. That helps us manage stress. You are socially connected here today, yes? Yeah. It's 100 and some of you here in the room, almost 150 people signed up for today. We are socially connected, and this is really important. It's good for our physical and mental health. Okay? So I kind of zipped through my stuff, and I'm pretty sure you all have a lot of questions. So even the small drops help fill a small pond. Are you willing to make small changes to help displace that big pond of osteoporosis? Are you willing to do that? So I'm going to invite you now to have questions for myself, for Allison. Suki has another microphone so she can hear the question and then you can hear us answer. Feel free, I'll get this out of here. There we go. Hold on up. All right. Anybody have questions? I'm sure you have questions, and I bet you I know what most of them are about. Right here I have one. Yeah.
Rhonda, I do the walking club every week.
Yep.
And then I have Joe Fish.
Yep.
That's good exercise.
Those
We
are
do
great
breathing
exercises,
and-
but it's not enough.
Yeah.
So with osteoporosis, walking, just walking, because I always say walking alone, I don't mean walking by yourself. I mean just walking as a form of exercise is
Yeah.
not enough to stop the progression of osteoporosis or even reverse osteopenia. We
Yeah.
want to keep those numbers from going the wrong direction.
I'm
It's-
always walking up and down the stairs.
Good. That's,
and
we want to add
everything
some
and-
strength training. How many days a week are you working with Joe?
2.
2? That's
Tuesdays
excellent.
and Thursdays.
See if you can add something over the weekend, something strength training on the weekend. Can
like
you
maybe take a walk down
something strength
around.
related? So instead of the walking, something like lifting weights, doing
yeah.
squats, doing
I'm always
something
doing squats at home.
to strengthen your body because we want to strengthen those muscles. That's a really good question.
Yeah.
Thank you. Suki's got right behind you. There you go. Who else has questions? Way, 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 way in the back. Oh, I see those coming. Hi. And those questions are not for me. Those questions are for you. Those are my people back there. They have access to me twice a week.
Rhonda's right. It's for the
I know
other
these
person.
questions are not for me.
Is it ever too late to start the drugs?
No. Short answer. Generally speaking, we say if somebody has a life expectancy of at least a year, it makes sense to start a medication and reduce fracture risk.
Okay, I'll get you next.
If you've had osteoporosis for quite a while and you've chosen to just do exercise and diet, and is it still important to occasionally have a bone density a test, and if your back is bothering you more, also perhaps x-rays or CT?
Yes, absolutely. I would recommend it. If you have opted for lifestyle management, that is fine. We still like to monitor and get a baseline bone density every 2 years or so. Also, if things change, right? You could have had compression fractures you didn't know about, which would give more evidence for wanting to potentially treat. I would say the best thing to do is continuously have a very open conversation with your provider about it. It's not just their decision, it's your decision as well for what you want to do. And so you kind of have to meet at a happy medium for what you are willing to do and what not to do. But yes, absolutely, I would recommend still continuing to get your bone density.
Thank you.
And if I am your person that you're seeing for fitness, I want to know that too. So I can help adjust your workout to say, oh, we're not going to do this anymore because now we know new information. So it's good not only for you to know, but for the professionals you're working with.
Okay.
Bunch of questions up here. One over there, one over here. Oh, go ahead.
Hi. I have a question about the activity level or the kinds of activities you should do or should avoid if you already have osteoporosis that's pretty severe. Twisting or bending, or what kinds of things should you avoid in order to, keep yourself safe?
All right, here's my marketing answer for that. I address all of that in the 6-week basics program. However, that's not the answer you're looking for. We do have a 6-week program here. It's Osteoporosis Beginners. It is a prerequisite to go to the osteoporosis maintenance exercise class that we offer twice a week. And that's one of the things we address in class, but I can tell you briefly, we often, in a group setting, it's general information, it's not for individuals, that you don't want to forward fold, side flex, and twist. Now we all need to rotate, that's how we walk naturally, but twist meaning adding force. And there's lots of ways we tend to do that. There's exercises we've done. Many of us grew up doing exercises. Whoever's laying on the floor doing bicycle crunches, that does 2, almost 3 of those things at the same time. We just don't do that anymore. So what do we do instead? And that's where fitness professionals like myself come in to help you with that. But yeah, is that what you would advise as well? Forward flexion, side flexion, and forceful twisting.
Not a lot of activity, especially like crunches, things like that. Anything that's going to require you to lay on a flat surface and curl the spine on. You don't want to do that. It's not a great time to start trampolining. I had a patient ask me if it was okay if she jumped out of a plane for her grandson's birthday. I recommended she not do it. She might have still done it, but I haven't seen her back. She's been on medication. She didn't break anything. So there's my plug. Yeah, it's not the jump, it's the stop.
I'm going to get her and then I'll get you.
Hi, I'm 77. I've never had a bone density. Is that something I should ask my doctor about? Or she
Bet you
just
should.
say
Yep.
it?
Next time you see your doctor, even now, shoot him a message. Hey, saw this awesome presentation at the senior center. Can I have a bone density? And your insurance should cover it.
Great question.
Hey, I got a question for Rhonda. I have osteoarthritis. How do you modify a squat and lunge?
So one way we modify things, so often sometimes people with osteoporosis have other conditions, and osteoarthritis is one of them, two separate things. And their easiest ways to modify those is shortening the range. So I can squat and go all the way to the floor, but this is also a squat. Walking is lunging, technically. But we can also change how we do this and start to do things seated, and maybe we extend the knees from a seated position. So we can always change how we do a movement that moves the same joints, focuses on the same muscles. Does that make sense?
Yes.
I'm going to change my middle name to options because I have options for everybody. No, there are no excuses in my book. Suki, I got one up front too. Here. After that one, I'll give you my mic.
Once you've taken one of these medications for 5 or 10 years, like Fosamax, does that mean you can't take anything in later years? I took it in my
Nope.
40s or 50s.
That's a great question. You can absolutely go back to them. So if you use Fosamax, let's say, and you were on it for 5 years, and then you stopped it for a period of time, you can go back to that same medication, or you can go to another medication. There's certain times we don't want to continue like certain ones one after another, but we would know that and we wouldn't choose those meds in a distinct order for you. But just because you've used it in the past, especially if you were in your 40s and 50s, and then we progress to this point, we can totally go back to those choices, okay?
What happens if you make a decision to take the medications and you do develop side effects?
We talk about it. We have you come in, we see what those side effects are, we make decisions like, is it worth continuing to try based on whatever the side effect is? Is it not? Should we switch to something else? There's a whole lot of factors that would go into that. So, individualized.
I have a question. You said good sleep. I have a sleep apnea and I listen to music and I still don't get a good sleep. What is your recommendations?
So it sounds like you're already taking actions to help with your sleep. Sleep apnea, for those of you who don't know, it's the inability to get enough oxygen in. Some people stop breathing while they're sleeping. And do you use CPAP machine? Okay, so a CPAP machine forces oxygen in so you don't stop breathing in the middle of the night, which is a good thing. And then the meditation you said as well, like an app that you listen to. Okay. It's not heavy metal, right? Okay. It's nice little meditation music. Okay. So what else can you do to increase or improve your sleep from there? There's a whole list of things that come under the category of sleep hygiene. That doesn't mean how I get clean before I sleep. It means how do I create a space that allows me to sleep? Is your bedding comfortable? Is it clean? Is it soft? Is it too heavy? Studies are now showing one sheet, maybe a cotton blanket is all you need. All right, so far so good. We're doing everything right so far. We could do some yoga. Have you worked out or have you done some exertion of energy during the day? Because that helps us sleep at night. Excellent. Good. So the yoga might help as well, but some other physical activity too, whether it's walking or strength training, that's going to help you exert some energy during the day, and now our body says, oh, now it's time to sleep and regenerate. You can switch your music that you're listening to something called Yoga Nidra, Nidra, And it leads you through really fast. You don't have to follow along. You just listen to it. You lay there and you lay in bed, and it plays this meditation and says, relax your right arm, relax your right pinky, your right ring finger. And it goes really quickly. You might find you fall asleep. Are you falling asleep or you're not staying asleep? Neither. None of the above. Wide awake, doing the taxes. Got it. Okay. Painting. At some point, if those easy things don't work, it's time to have a conversation with your healthcare provider and say, I'm not sleeping. Do you drink caffeine? Me either. Okay. When was are you up? I'm going to ask personal questions. Are you up using the bathroom because you've had a bazillion glasses of water during the day? Okay. Okay. So it's not because you're waking up and have to. So you got something going on. Maybe it's time to have a good conversation with your healthcare provider and say, hey, I'm doing all these things. My room's not cluttered. My bed is comfortable. My sheets are what they should be. My pillow is there. I'm not overheated. I'm not too cold. So yeah. So it might be time to have a good conversation with a healthcare provider. Try the Yoga Nidra. You can look it up. If you have Netflix, you can find it on there. It'll play it. If you have Prime Music, it'll do that. You can find it. YouTube has it too. And you don't have to see it. You just want to listen to it. And blue light. We're going to turn off all the blue lights in our room. I have gone so far as to put a piece of black electrical tape over the little red light on the power strip, because even that bothers me. So I don't like lights. Hotel rooms and I know. Yeah. So yeah. More questions? Suki?
I have a question over here.
Oh, you got the remote.
I have a senior asking a question that she asking, what are the difference of vitamin D and calcium? What the same? And sometimes she thinks that sometimes the doctor telling her to take both, or at least sometimes the doctor.
So I'm going to answer the easy part, and then I'm going to give you the hard part of that question. Calcium and vitamin D are two different things. Calcium and vitamin D are both found in food. Our body can make vitamin D, but not enough of it because we live here in a place where it's not sunny enough and our bodies aren't exposed enough. So we do take supplements for that sometimes when we need to. They can prescribe a supplement that has both of them together. So they are two separate things. You probably have a more in-depth answer to that.
You can, over the counter, also get them either separately or together. They put them together because if you need one, you generally need the other, and they're going to help with absorption and things like that. But as far as we're concerned, sometimes it's easier to keep things separate just in case we have to adjust one or another. Say your calcium level is too high or your vitamin D level is high. If you've already bought a combined supplement, sometimes it's a little bit trickier to just adjust one of those without having to spend more money on a supplement. But if you've been very full on the same dose for a really long period of time, get them in a combo. I mean, go for it. It'll help minimize how many pills you have to take per day. You just kind of have to be aware that those milligrams and international units and micrograms, they will vary from supplement to supplement. So if you're switching and you're going from 2 to 1, or you're separating your 1 supplement to 2, just make sure you check the doses and make sure they are the same amount.
Okay, thank you.
You mentioned Forteo and, I don't know if I'm pronouncing it right, Tymlos, those parathyroid medications. Do you use those fairly often, and what kind of success rate do you find with them?
Yeah, we use those all the time. So this is all I do. So all of those meds that I mentioned, I am prescribing all of the time. When it comes down to choosing the medication, like I said, sometimes it's insurance that'll kind of dictate what we choose, but I like to leave it in the hands of the patient as far as patient preference is concerned. If you're eligible for multiple different medications, why not make the best choice that's going to work with your lifestyle? And so I have a lot of people come and see me, and they prefer a monthly injection because they don't want to inject themselves every day. But then there's a whole subset of individuals that don't want to come to clinic, or they're already injecting with insulin every day, so what's another injection? And so, yeah, I recommend those often. And as far as success is concerned, between all of our bone rebuilding therapies, generally outcomes are similar with the ultimate goal of reducing or improving those T-scores. So say you started at a -3, bringing it somewhere higher is better. On these medications, most of the time I will have patients have improvement overall in T-scores. I have had certain cases where people went on bone rebuilding therapies and their T-scores didn't change, but even then we can say there's a reduction in fracture risk because without the medication, by and large, those T-scores in all likelihood would have worsened.
And if I could ask an additional question as well. If I understand right, those medications are not biological ones that stay in your system a long time, like a Veneta, or may not be pronouncing it right.
Yeah, so it's daily dosing, so it's designed that way because that med doesn't last so long in your system. So if you were to start it and have a side effect, generally speaking, like you can stop it and it will be out of your system relatively quickly because it's a daily dose.
All right.
Yep.
Thank you.
I just have a question, and my question is there anything that inhibits the absorption of calcium? And I know you talked about like alcohol, smoking, and things like that, but is there anything else on a regular basis people should be aware of?
So you want to try to time your calcium away from like an acid blocker, like if you're taking Pepcid or Prilosec or something like that. You'll want to avoid dosing those like really close together. Generally on those, you'll have less absorption, which is why we suggest the calcium citrate if you have underlying reflux instead of calcium carbonate. And that's why it's just better getting it in your diet because it's all absorbed better. With the ultimate goal at the end of the day to have a total of 1,200. That help? Yeah.
There are chemical compounds in food that can block calcium. Phytates and oxalates are two of them. So we do talk about that a little bit more in depth in the nutrition portion of the 6-week class. You've done that with me, haven't you? Yeah. So you know the answer to that question. Right. So there are some foods that can inhibit the calcium in the food that it's in. So if a bean has a phytate, it'll inhibit the calcium absorption of the calcium in the bean, but not the cheese that you put on your burrito. So yeah. There are some. You had a question as well.
How you evaluate after you take the medication? Because I was a little bit hesitated to take the medication because of the side effect. But if the evaluation comes out good, I'm willing to take the chance.
And I wish I had a magic ball so that I could tell you, yes, you'll take this and you'll be great. We reevaluate with continuous bone densities over time. So we try to have a baseline bone density, like a starting point from where you are pre-medication. And then generally speaking, we'll repeat the bone density every 2 years. That's because of insurance. Some insurances, like Medicare, we can get away with it every year. It depends on the situation. So generally with bone density, we also monitor your fractures. If you've had any fractures, if you've not had any fractures, we can say success with the medication. There's also, and this gets a little bit more into the science of things, but there are certainly some blood turnover markers, bone turnover markers that we can measure pre-treatment, during treatment, and after treatment that helps us to see, is it working and having the success that we want it to? And it depends. At a baseline, if for people that are really scientifically minded and they want the data, like it sounds like you want, we would do it pre-treatment, and then depending upon which treatment we chose, usually within 3 to 6 months, we would repeat those. And then again, after treatment, and if we did a holiday, so to speak, meaning you're off the medication, we'll measure periodically during that time frame too to see what your bone turnover is. If it's high, maybe we consider going back to medication. If it's low, we can say that medication is still working. So a lot of really dynamic decisions into that. So there's a whole lot of other information I'd need to know to be able to say, this is the one that I think would be best for you. So, and that would go into like a history of questions with you to figure out which one I think would be the best choice. Yeah, it depends. Yeah, which is great. That's a good thing. Yeah, it keeps your options open. Yeah, so side effect home shot, to reiterate, injection site reaction is usually the most common because that one's a daily injection. It's a little needle, but you can still get irritation at the site of injection, sometimes bruising. So you rotate, you work your way around the abdomen. Sometimes you can use the thighs is fine. That's probably most common. The second most common that I mentioned is that dizziness following the injection. And about 10 to 15% of people will get that. Usually giving it to yourself at nighttime before bed, you can correct that. There is, and this is kind of scary, and I didn't mention it, but a low risk of something called osteosarcoma, which is bone cancer. So with those daily injectable medications, we don't use them in people that have a history of radiation treatment for cancers or things like that. Generally, that risk is quite low, but something to consider as well. Mm-hmm. If they're going to cover it, sure. The low X-ray that they use with the bone density, by and large, will not accumulate enough to cause a problem. Yeah. Yeah, kind of. Yeah.
Is there much of a difference between the calcium supplement pills and the fortified foods like the milk, calcium, or some others in it, you know, the more natural ones versus the pill?
No, in general, no. Whatever route you want to go is fine, as long as you're getting 1,200 milligrams a day. Some people are, you know, lactose intolerant or things like that, and they can't tolerate, you know, cheese and milk and fortified dairy. And in those cases, they have to supplement. But I have a slight preference for dietary calcium if you can do it, knowing it's better absorbed and tolerated. But whatever way you have to get there at the end of the day is fine.
Can you do it as a vegan?
You must be able to. I'm not super familiar with a vegan diet, but that's nothing the internet probably can't help us figure out.
Quick question, Allison. I had a bone density test, I don't know how many years ago, and then I went to my doctor, and she said I didn't need one. Should I ask her for another one just to be safe? You think?
Yeah. If it's been more than 2 years, absolutely. Yeah, I would. Because your insurance will cover it, and then the more info you have, you know what I mean? Yeah, ask her. I find they're pretty open to that. Sometimes with osteoporosis, because it's not causing symptoms or problems until it causes a problem, it ends up being, especially for primary care providers, and there's so much else to talk about, kind of ends up being like one of the last things on the list. So be your own advocate and ask for it. Yeah.
I have a question over here. So how do like for the pills you can measure like how many milligram, but for diet, how do you know that you get enough for like enough for 1,200 milligram a day?
There's great websites for that, and so it'll say the name of the food and then generally how much calcium is in a serving size.
Okay.
And if you can estimate your serving size, then you can just do the math.
I see. Thank you. I have another question. Like, if someone not be able to tolerate like dairy products or milk, like soya milk, is that count?
If it's fortified, also like almond milk is super high in calcium, so that is a great alternative. Oat milk, variations of other nut milks, walnut milk, things like that.
Okay.
You can find it in those as well.
Okay. Thank you.
Meredith?
So my mom found the slow release calcium, and it says to take it just once a day. Is that okay?
Citracal, like slow release? Yeah, I would say yes. If that's the one that she can tolerate, yeah, fine. It's great. Any other questions?
Hi, everybody. So this is not a question. This is free advertising. So there was a question about osteoarthritis, and we know that lots of our patients have both osteoporosis and osteoarthritis. And obviously, osteoarthritis is a huge issue as well, right? Because we don't have medicines which change the trajectory. So everything we're trying to do is, number one, minimize symptoms, and number two, keep people as functional as they can be. And we have a colleague at UMass called Tim McAlinden, who is a world expert on osteoarthritis. And he's looking for people with knee osteoarthritis to see if they would be willing to participate in a trial of vitamin K supplementation to see if that helps with symptoms and function. So there are some flyers just over there underneath the big TV. And if anyone's interested, please take one, take a photo, contact details are there. And they're looking for anybody and everybody, okay? So if we can help him out, that'll be great for all of us. Thanks.
We're going to put those flyers. So there's flyers on the table, and then there's we'll put some up in the gym, and Rhonda will have some. So it'll be accessible.
Is anybody here over the age of 35?
Do you want to do our one last question? Oh, okay. Two last questions.
Based on what he just said about the study that they're doing, my thoughts were, if a person has osteoarthritis, is that a precursor to osteopenia, or did one come before the other?
Yeah, what came first, the chicken or the egg?
Right.
Yeah, does osteoarthritis cause osteopenia or osteoporosis?
Right.
Or the other way around? No, short answer is no, but they often coexist simply due
I was
to
wondering,
aging.
where does that
Yeah,
fall?
every little bit of your body gets older, and both of those generally happen as we get older, and so often they are coexisting. But there is not a simple answer to chicken or egg coming first.
Hi. I have osteopenia, okay? And soon as my doctor seen the results on my bone density and told me I had osteopenia, she put me on the vitamin D 2000 and the gummies, calcium gummies, plus that also has the bone strengthening in it, D3 also. Now, what's the chances of me getting osteoporosis now?
That's a loaded question. I don't know. I don't have a crystal ball. And that's and that is why re-measuring your bone density is important every few years. Unfortunately, once you've reached the level of osteopenia and osteoporosis, there's like no level of D in calcium or exercise that is really going to be able to reverse that. It can stabilize things, but there's a lot of factors that go into you individually and what would precipitate a worsening osteoporosis or if things just stabilize at that point. And that's why we repeat the bone densities. And here's just a little plug. As far as repeating a bone density, try to have them done at the same location. So when you go year after year, if you had one done at University campus at UMass, try to have the next one done at University campus at UMass. Don't switch locations and then next time go to St. V's or go to Marlboro, because it goes from comparing apples to apples to oranges. When we go to repeat them, if they are done at the same location, we can make a pretty adequate comparison. If they've been done at different places, especially on different types of equipment, we can't. Okay, so that's something to remember too when you have your repeat bone density. You're welcome.
Who orders the bone density? Your primary care or your orthopedist?
Could be both. Usually it's the primary care, especially with the first one. And then it kind of depends who you're following with for management that would order the next one. Sometimes it ends up being us in our office, since we've kind of taken over management of that. But a lot of times the primary care will just keep ordering it. A lot of times with women, it's the OBGYN that'll order it too. Sometimes the first one or sometimes the subsequent ones. So it all depends.
Okay, thank you.
I have 3 children, and I have osteoporosis. My mother's alive. She's 91. She, as far as I know, does not have a history of osteoporosis. What should I tell my children?
Great question. So is anybody 50 yet? No. So yeah, I know. You had them when you were 2. But generally speaking, unless they've had a history of frequent broken bones, I would recommend that their treatment or their screening would generally start somewhere around the age of menopause if they're female, and if they're males, a bit later down the road. But it's something for them just to keep on their radar and ask their PCP about as they get older.
Now's a really good time to work towards preventing it, though.
Yeah, D, calcium, weight-bearing exercise can keep it from happening.
Terrific program today. Allison Money and Rhonda Hammer, thank you so much.